Welcome to the January 27, 2022 Medication Error Reduction and Workforce Committee meeting. My name is Nicole Thibault, chairperson of the committee. As this is the first meeting of this committee, I would like to thank President O for establishing this very important ad hoc committee and the opportunity to serve as the chair. I believe medication errors are the #1 patient safety issue facing pharmacy. I look forward to our discussion on the various topics. I'd also like to take this opportunity to welcome our newest board member, Kula Koenig. Thank you very much for being here. Before we convene, I would like to remind everyone present that the board is a consumer protection agency charged with administering and enforcing pharmacy law. Where protection of the public is inconsistent with other interests sought to be promoted, the protection of the public shall be paramount. This meeting is being conducted consistent with the provisions of Government Code Section 11133. Participants watching the webcast will only be able to observe the meeting. Anyone interested in participating in the meeting must join the WebEx meeting. Information and instructions are posted on our website. As I facilitate this meeting, I will announce when we are accepting public comment. I have advised the meeting moderator to allot 2 minutes to each individual providing comments. This approach is necessary to facilitate this meeting and ensure the committee has the opportunity to complete its necessary business. I appreciate everyone's understanding. Before we get started, I would like to ask the meeting moderator to provide general instructions.
Thank you. This is the moderator. For today's public comment session, we will be utilizing WebEx's question and answer feature. You will hear me refer to it as the Q&A. When public comment is called, I will open the Q&A feature and display the following slide. This will give you instructions on how to access that Q&A feature. You're going to be looking for the Q&A icon on your screen. Looks like a question mark inside of a square and is typically located at the bottom right corner of your screen. When you click on that icon, it will open a text box. In that text box, you can type the word comment and submit that to our panelists. When I call on you for public comment, I will let you know that I've sent a request to unmute your microphone. At that time, you will need to click the Unmute Me button that appears at your end. The first time you click on this button to make public comment today, it will play a brief recording through WebEx. You'll need to wait till that recording stops before speaking. Otherwise, we will not be able to hear the beginning of your comment. For subsequent public comment requests, it should not play that recording. We will be taking comments in the order that they are received. And as the chair mentioned, you will have a 2-minute time limit. I will be providing a 15-second warning when your time is about to expire. When your time does expire, I will let you know that it is expired. Mute your microphone and move on to the next commenter. And with that, I will turn it back over to the chair.
Thank you, moderator. I would now like to take a roll call and establish a quorum. Members, as I call your name, please remember to open your line before speaking. President O.
Here, Nicole. Thank you. Good morning.
Thank you. Cheryl Butler.
Good morning, Nicole and everyone.
Morning, Cheryl. Kula Koenig.
Good morning.
Morning, welcome. And Jig Patel.
Good morning.
Hi, Jig. And I am present, so we have a quorum. With the quorum being established, the committee will now entertain any public comments for items not on the agenda. To facilitate this portion of the meeting, as I previously announced, the meeting moderator will open up the line for individuals to provide public comment. You are not required to identify yourself, but may do so. As we open the lines, I would like to remind everyone that the board cannot take action on these items except to decide whether to place an item on a future agenda. Members, following review of the public comments for this agenda item, I will survey members to determine if any members have preference for items to be placed on future agenda. Moderator, please open the line.
This is the moderator. We've opened that Q&A panel. If you'd like to make a comment for items not on today's agenda, please click on the Q&A icon on your screen. Type comment into the text field and submit that to our panelists. And I'm not seeing any requests at this time. Would you like me to close the panel?
Yes, please close it. Thank you.
You're welcome. It is closed.
Great. And with that, we're going to move on to our next agenda item. This is discussion and consideration of Institute for Safe Medication Practices, including resources available. Members, we're going to take agenda items out of order and start today with agenda item 5, discussion and consideration of ISMP. I am pleased to welcome to our meeting today Dr. Rita Zhu and Dr. Michael Gaunt to provide a presentation on ISMP and the resources it provides.
Good morning, everyone, and thank you for having us. My name is Rita Zhu, and I am the president of the Institute for Safe Medication Practices, and most of you know of us as ISMP. I will start out our presentation by providing you with a brief overview of ISMP, and then my colleague Michael Gaunt will discuss the tools ISMP offers to address medication error risk. But before I begin this presentation, I would just like to have Michael introduce himself. Michael?
Yes, good morning, everyone. Like Rita said, thank you for the opportunity to discuss ISMP and our tools with you all. I am a pharmacist and been with ISMP for about 17 years, and look forward to the discussion.
Great. Thank you, Michael. And if we can advance to the next slide, please. So as I say, I will start off by telling you a little bit about ISMP. So if we can go to the next slide. So the Institute for Safe Medication Practices is a 501c3 nonprofit organization that was founded by our founder, Michael Cohen, as most of you know very well, in 1994. Our mission is advancing patient safety worldwide by empowering the healthcare community to prevent medication errors. And while we have influenced a lot of safe medication practices in the US, our impact is indeed worldwide. Our founder, Michael Cohen, has also co-founded the International Medication Safety Network, also known as IMSN, that has members from 25 countries around the world, with the WHO representatives participating as observers. We also have 3 other sister organizations, ISMP Canada, ISMP Spain, and ISMP Brazil. In 2020, we joined with ACRI to form one of the largest patient safety entities in the world. So we operate an AHRQ certified patient safety organization called the ACRI and the Institute for Safe Medication Practices, PSO. Both our staff and advisory board members are multidisciplinary. So we have pharmacists, nurses, and physicians on staff and on our advisory board. Next slide, please. So we hear directly from and interact with practitioners and consumers through our medication reporting program that I'll be talking to you about in a little bit. We have huge impacts on products-related issues such as look-alike, sound-alike medications, practice-related issues on anywhere from the use of tall man lettering to differentiate look-alike, sound-alike medications in the appearance on EHR, as well as just storage and in inventories in pharmacies. And we definitely impact safety culture through our promotion of just culture. Our recommendations are respected and acted upon definitely by healthcare practitioners. A lot of healthcare practitioners have adopted our best practices, and so is professional organizations like the American Society of Health System Pharmacists and accreditation bodies such as the Joint Commission. We also have direct impact the work of the Food and Drug Administration, which we will be talking about in a little bit. Next slide, please. So where does ISMP get its information? This is really through our medication error reporting program. Our current medication error reporting program originated with a monthly journal column by Dr. Michael Cohen called Medication Error Reports that began publication in March of 1975. So the root of ISMP really started in 1975 in the journal Hospital Pharmacy. And this advocacy effort focused on de-identified medication error stories and prevention strategies that has prompted pharmacists across the nation to report errors to share their lessons learned with other pharmacists. And so this column was expanded to a nursing journal in 1977, which we also encourage nurses to report errors. So that's with that brief history of ISMP's existence, you would not be surprised to hear that up to today, we rely on healthcare professionals and consumers to supply us with information as the basis of our work. So we have a consumer medication error reporting program where consumers connect directly to us to report errors. We have practitioners reporting errors directly to us via the ISMP medication error reporting program and the vaccine error reporting program. We also have other sources, just basically folks just emailing us when there is concerns of issues that they have uncovered that they'd like us to investigate and share information for. And from all this information, we disseminate information to our practitioners, to organizations, to consumers, and regulatory agencies and industry through our newsletters. So next slide. So here's a screenshot of our website where the error reporting button is, and this is where folks would just come on our site to report the errors. Next slide, please. So with the error reporting program, we receive narrative information from providers and consumers, and this is really just all from the altruism that they wanted to share information with the broader healthcare community. And this is a key to our success nationally and globally. Our information that is collected are always confidential, and it can be legally shielded from discovery if requested. And based on the errors that are reported, we interact with mostly at the beginning of the investigation. A lot of times we'll interact with manufacturers, but we also interact with regulators, standards organizations, accreditors, professional organizations, and even pharmacovigilance agencies. And once we have investigated the error, we would come up with recommendations and strategies to prevent future errors from happening. And we inform the healthcare community through 5 of our newsletters. We have an acute care newsletter, we have a nursing newsletter, we have a community and ambulatory care pharmacy newsletter. We also have a long-term care newsletter and a consumer newsletter. And our goal, as I've said, is really to help share the information about potential risk of errors and also ultimately to hope to prevent errors from happening. Next slide, please. So as I've said before, we directly influence the work of the US FDA, and this is through a memorandum of understanding with the FDA that has been longstanding for years with the Center for Drug Evaluation and Research, or we all know of it as CDER, for many, many years. And just last year, our MOU was updated and expanded to include work with all departments and divisions of the FDA. So we're very excited about that partnership, the continued and expanded partnership with the FDA. The FDA and ISMP hold regular monthly meetings to discuss regulated product issues, and all of the information that we share with the FDA are publicly available. Publicly available information on medication error information. We discuss regulated product issues. A lot of it surrounds nomenclature, labeling, and packaging, but we also have discussions about medications and medication-related devices. ISMP and FDA also share a fellowship program, which is completely funded by the FDA, where our fellows would spend 6 months with the ISMP and 6 months with the FDA. And finally, FDA guidance statements. A lot of the guidance statements were based in part on ISMP's reporting program findings. So with that introduction, I'll hand this over to Michael to tell you a little bit more about our tools to address medication error risk.
All right. Yeah, thank you, Rita. And good morning again, everyone. So for this portion, really going to focus on some of the resources we have for the community ambulatory space. One of the roles I have at ISMP is I'm the editor of our community ambulatory care newsletter and get involved with a lot of our community ambulatory care tools and things like that. So I just want to let you know up front, though, that we do have additional tools to what we'll go over today for other settings, such as long-term care or in particular acute care settings, where we have a number of different guidelines, documents, and other resources for those settings. But if you could go to the next slide, please. Rita briefly mentioned, that we have a number of newsletters that we publish on various cadences. The one that we're going to focus on here is the Community Ambulatory Care newsletter. And this is a subscription-based monthly newsletter has been published starting way back in 2002. And as Rita alluded to, a lot of our work is driven by the reports we get from consumers and directly from practitioners. And so we're not getting data from like the corporate pharmacies themselves usually, or even like institutions. It's individual practitioners, whether they're pharmacists, nurses, physicians, or pharmacy technicians or students, sending us information. And as we get that information, we analyze the reports, interact, as Rita said, with the reporter, with FDA, with manufacturers, with others that we need to reach out to try to really understand what happened and come up with recommendations for how to prevent those errors. And so we use the newsletter, our newsletters and this one as well, to really serve as an early warning system and as a way of disseminating the learnings from the individual error reports that we get in, to be able to share them proactively with others who are in practice in pharmacies or in hospitals. And really look at this for pharmacies to use this as a proactive tool for themselves to as part of their continuous quality improvement programs, to really look at information from outside of their organization, to learn about things that are happening in other pharmacies that are likely, those same risks are likely present in their own pharmacies. And so when folks subscribe, pharmacies can subscribe. We have group subscriptions as well. But once they subscribe, we encourage them to share it with all of their staff. So all of their staff are seeing what's published, to give them insight into the types of errors that are happening, and so that they can then incorporate that into their workday and possibly identify similar things or different things, but really share that learning so folks can address risk in their pharmacies. If you want to go to the next slide, please. A piece that goes along with our newsletters, but this is freely available to folks on our website. We do this for our acute care newsletter as well as our community, and we call them action agendas. So for the community, it comes out every 4 months, January, May, and September. And what we do is go back through the previous 4 months of newsletter material and pick out key pieces and put them into a table. Like you see here, a PDF of our table. But the acute care, the community version is usually 3 pages, and we have it available in Word, PDF, and Excel. But really pull out the key pieces of what happened or the problem, as well as the key recommendations, and set up in a table so practitioners can come together and look at this as a kind of an easy tool to look at and assess, use it to assess the risk of these problems in their pharmacy. And this is one thing, as we get into the discussion of future steps or things, that the board can consider, is thinking about encouraging folks to use this and possibly even offering some small amount of CE to California licensees to do this. We've worked with other boards in the past on other tools of ours where they've offered CE for their licensees. And this would be probably another good tool to encourage folks to use. And like I said, it's only 3 pages, so it's easily digestible. And it's a way they can also track their assessment as well as their action plan for improvement. The next slide, please. And some of you may have seen our NAN Alerts. I know Anne has been doing a great job of forwarding those around to folks. But we have a couple different types of alerts we'll do from time to time. But the main one is the NAN Alert, which we do in conjunction with the American Society for Health System Pharmacists, as well, and the National Coordinating Council for Medication Error Reporting and Prevention. And these are things that rise that really need immediate attention and national attention to help prevent errors. So as you can see here on the left, the most recent NAN Alert is about the age-related mix-ups with the COVID-19 vaccines. One previous to that was, we've had lots of reports of mix-ups between flu and COVID vaccines as well. But it's a way of getting the word out. And again, thank you to Ann and the California board for circulating this to your licensees, because it's, again, another avenue to alert folks to critical safety issues. And then from time to time, we also do these other types of special alerts. And this one just came out at the beginning of January about the packaging and potential issues with the new Paxlovid product to help prevent serious COVID disease. Go to the next slide, please. One of the big tools that we really like folks to encourage folks to use, and we had been doing these self-assessments for really 2 decades now, are what we call our medication safety self-assessments. And we have a number of them for different settings and for specific topics. But really, since about 2002, we've had one for community ambulatory pharmacy, and we've been updating it various times over the years, and we are currently finishing up a new update for that as well. But these are tools designed for pharmacies as a whole to use to assess risk within their pharmacies. So they're not intended for individuals to use, really, again, for the pharmacy team to use as a whole. And they're designed around our 10 key elements of the medication use system, way we think about safety and how systems interact, from like patient information, drug information, quality and risk management, patient education, and things like that. And so these self-assessments are really kind of divided into like 10 sections, one for each key element, and have a number of elements within each one. And they're a really good way for pharmacies to identify potential risk issues in their pharmacies, as well as then help them identify and start to plan how they're going to, over the long term, fix, or try to correct those safety gaps and those risks. We are starting to do more work in the specialty pharmacy area as well. And so we've also developed a self-assessment tool for specialty pharmacies. So the updated community pharmacy one, as well as the specialty pharmacy one, will be released this quarter. The pharmacy one will have a publicly available PDF free for folks to use. And then we'll also have an online platform for both of these where people, if they choose, they could pay a fee and be able to enter data online, track their progress over time potentially, and then also get some comparison aggregate data or be able to compare themselves to aggregate data as well. But this is another tool, especially the community pharmacy self-assessment, that we can have more discussion at the end about ways board staff can possibly use this as well. You want to go to the next slide, please? So most of the things I've talked about already are kind of proactive tools. These two are more reactive or event investigation type tools. So a number of years ago, we developed this root cause analysis workbook for community pharmacy. That is also under revision right now, and that should be released sometime soon as well. But it really boils down the root cause analysis process into kind of easily digestible bites for community pharmacies. We don't get a lot of training as pharmacists or even healthcare practitioners in general about event investigation or root cause analysis. So we really designed this workbook to give the key pieces of information, the key tips for how to do an RCA for the community setting. And we also include a number of case examples as well as blank forms for pharmacies to use. And then the document on the right is an assessor form. This would be something that pharmacies could use to respond to individual events more kind of in real time. And again, try to identify potential contributing factors by the different key elements. We are aware of some community pharmacies, I'm not sure that they're in California, but in other states who actually use this as part of have incorporated this into their own internal error reporting forms, and they'll share those with us from time to time. So there are pharmacies out there using this. I'm going to go to the next slide, please. And so not only do the error reports really fuel the content for lots of these other tools, the self-assessments or the newsletters, but also are the basis for some of our other recommendations and free tools out there, some of which are pictured here, and really draw your attention to the high alert lists in this particular case. We have lists for acute care settings, long-term care settings, as you can see here, as well as the community ambulatory care setting. Long-term care and community were just updated this past year. But this is, again, another tool for pharmacies to use, and something we can talk more about at the end, to really identify drugs that require special or additional safety strategies, whether that might be patient counseling or it could be storage-related things, HIT, or information technology-related fixes, but as a way of targeting and identifying specific drugs or drug classes that help them target some of those strategies. I want to go to the next slide, please. And in this space, we also have tools that pharmacies can actually use with their patients and with consumers. We have a number of these patient high alert medication learning guides for consumers. And here are a couple. You see methotrexate, Xarelto, but we have them for fentanyl patches, the various insulin products, some of the other opioids, and other anticoagulants as well. And some are also available and have been translated into Spanish. But these are 2-page learning guides. The first page here are kind of like 10 tips to really guide that interaction between pharmacist and consumer or patient, to highlight key medication error risk potentials with the different drugs and how to prevent them. And the second page kind of gives more kind of general drug information as well as a case example. But we really encourage pharmacists to use these. These are free. They can print them, download them from our website as they want, and really encourage them to use them with their consumers. As many of you probably know, the typical patient information handouts that are generated by pharmacy computer systems have good information, but not so much on the error prevention piece. And so that's where we saw these as a tool to fill that gap. Go to the next slide, please. So that's really kind of the end of the presentation for our current tools. If you want to go to the next slide, please. And we just had a couple other things to show you and some questions or thoughts that maybe we can discuss. So one of the tools we have currently available for acute care pharmacy or acute care settings is what we call the targeted medication safety best practices. We're beginning the process of developing a similar set of best practices for community pharmacies. And these are really intended to target safety issues that continue to cause harm or really introduce the risk of serious harm to patients and are kind of frequently reported or continue to be reported to us over a long period of time. So here you see there's a couple issues, drug-related issues that probably are not a surprise to you that we continue to get issues with. The dosing of oral methotrexate for non-oncologic indications is typically weekly, or it's typically weekly as opposed to daily. But we've gotten quite a few errors over the years, including over the last couple of years, where that drug is inadvertently dispensed and labeled for daily use instead of weekly use, and patients end up in the hospital. And we've had a number of patients who have died as a result of that. Another example is, safeguarding use of fentanyl patches and trying to really avoid use of fentanyl patches for acute pain and or in patients who are opioid naive. But these we'll be working on a set of these. The acute care set, I think, is like a dozen now because we've been doing it for a number of years. We'll add things, we'll retire things as different topics get resolved. But this is something to keep an eye out for over the coming year as we get ready to publish these. And there's the link for the hospital version. And then a couple of areas, Rita and I and Dr. Cohen were talking in the lead up to this presentation, our discussion, different things we thought that might be useful to talk out and ideas to kick around as far as what the board could do or what we could do together, or just even suggestions for other safety topics. And here are two, and we can talk about others as well. But like I mentioned before, with respect to the high alert medications and the consumer guides, we see that there's a real value in the patient education component for these drugs. We've done some research funded by AHRQ, the Agency for Healthcare Research and Quality, a number of years ago, and really found that interaction at the point of sale with the pharmacist and the patients, opening the bag of medications, can catch a lot of errors, like wrong patient errors, but also provides the opportunity to provide key strategies for patients to use at the home to prevent errors. And so we've often thought that there's a subset of high alert drugs that really would benefit from a much more mandated and possibly scripted patient counseling session. And obviously the mandating piece would have to come from the board, but there might be something to think about going forward around that. And one of the other things I wanted to bring up here is again, going back to the self-assessments. In some of the discussions we've had with other boards and past board members and past representatives at NABP, is how board staff and inspectors could really adapt or use the self-assessments themselves when they go into pharmacies as a way of facilitating safety discussions with pharmacies. So it's really, the items are really thought of as best practices, and really a way of going in and interacting with the licensees to discuss safety issues and have them start thinking about safety in a different way than what they normally do or come out of school thinking. But I think there's probably opportunities to where the self-assessments used in the right way could really benefit both the board and pharmacists and pharmacies in trying to address medication safety issues and really push safety culture and safety best practices to where patients medication errors are limited and patient harm is prevented. I think that's really the last slide. We have, just for the board's information, a number of slides after these question slides just for other resources, just so you have them as part of the slide deck. But at this point, if we have time for questions, that would be great.
Thank you so much for that very informative presentation. As a pharmacist, I can say your tools are so useful and much appreciate everything that you do. You've already said that it's all right, so I'd like to take this time to open it up to the board members to provide comments or ask questions. So board members, what do you have for them?
Hi, this is Song. If I may, Dr. Zhu and Dr. Gao, thank you so much for coming and giving us presentation. This is very informative, and we really appreciate what you guys do. I have a lot of questions, but I'll just start a few. So I know the error, obviously medication error is complicated and complex. I'm just curious on the level of partnership, if there's any with ISMP and large corporate pharmacies, and how much of the relationship is there. Because some of the self-assessment that I see, unfortunately, I don't see them in practice, it seems like. So I'm hoping that there is some more, relationships or some working possibilities together with the large corporate chains. I'll start there.
Michael, you want to start with that? You have a lot more historical perspective than I do.
Yeah. So I mean, historically, yes, in some areas, over the years we've done a number of different projects, and going years back. I will say, when we look at our tools and the self-assessments in particular, and when we start to address the targeted safety best practices, we do get representatives from the larger pharmacy operations involved on our advisory groups, for those things, so that they can provide us feedback, as far as the feasibility of different strategies and to provide feedback. We do have, obviously, our newsletter goes to a number of different places. Some of the larger organizations do subscribe to our newsletters as well for their entire corporations. Some of the large supermarket chains, mass merchandisers, and others. But on a day-to-day basis, outside of the newsletters, we do have the newsletters. Our newsletters are all peer-reviewed. I should have mentioned that. And we do have representatives from a number of different different organizations as part of our external review board as well. And we do have and will reach out to folks as we need to and as we can. But even with any organization, whether it's the large organizations or not, or even the hospitals, I think it's something we continually try to build relationships, with different organizations to try to address safety issues. Rita, if there's anything else you want to say.
Yeah, so I would say that unfortunately, we don't have a very close working relationship with the large chains at this point, and we definitely would love to work with them in addressing a lot of the issues that are out there in the community pharmacies at this point. But as Michael have said, we try. There definitely select members that are on our advisory group on various projects or in our newsletter, but not a really active engagement at this point.
Okay, thank you. And about the error reportings, are there any state boards around the country that have a some sort of a like a reporting requirements that, as far as you know, are like they're required to report certain things to the state boards or to ISMP? Well, anything along the line of that? Is there any other state boards around the country that have implemented that?
Well, first of all, reporting to ISMP is completely voluntary. So there's definitely no requirements to report to ISMP from any board of pharmacy that I'm aware of. And I don't believe, Michael, you may, since you have said on the NABP, I don't know of any board of pharmacies that have required reporting of errors to the board per se. I mean, there's definitely Department of Health and other agencies that have requirements for reporting, but to my knowledge, not board of pharmacies. Michael?
Yeah, Massachusetts would be one to look at, and I don't know the exact current state. They've had different things over the years, and I know that I don't know if it's across the board, or just for, in response to individual reports or complaints that they receive. But I know that we do get reports where the reporters indicate that the board has required them to report to us. And like I said, that Massachusetts stands out to me. I want to say the Virginia board, don't know the current status, not so much reporting, but at one point they were asking or requesting or requiring pharmacies to work with a certified patient safety organization. So it's not quite air reporting, they're kind of connected. Because I know we were getting a fair number of inquiries at one point from Virginia-based pharmacies. So I think there are. I think it's just some, but it's just not. I don't know how well spelled out it is, or how, how widespread that is now.
Gotcha. Okay, thank you. And as you know, the vaccine administration and community pharmacy it has and it's become even more huge part of it. And I try to look through the self-assessment to see, is there any plan to have a section dedicated for vaccine-related system issues, or is it just part of each section?
So at the moment, even with the updated version, the community assessment that's coming out this quarter, they're interspersed in the different parts because we really try to tie them in with the different key elements of the process. I would say that there might be a few more items in this new one. So it's around items around preparation, hand hygiene, interacting and documenting, checking and documenting in the state registries, and distraction-free areas. I know we've had inquiries and talked about more vaccine-specific tools, but we haven't gone down that path as far as the self-assessment goes in particular. So I think the new one has, I want to say around 10, might have up to 10 items around vaccine administration. And again, that would also be storage. So.
Okay, thank you. And lastly, about the section 7, I think under the staffing patterns, environmental factors, workflow, and staffing patterns. Like when you guys evaluate medication errors, do you consider in like what the pharmacy's working situation was at that point? Like how many people were working and how many techs were there, clerks?
Absolutely. Right.
Okay.
Yeah, and we do if we have the information, right? So these are all voluntary reports. If you're familiar with our various error reporting programs. The one for medication errors is very simple. When you come to our website, it's just 3 text boxes, and that we ask people to describe what happened, describe why they think it happened, and describe, kind of what they think could help prevent it. And certainly from the community side, we for some, so for reports, we'll get some of that information where the reporter will comment on staffing patterns contributing to the error, the volume of prescriptions for the day contributing to the error, things like that. The one thing we don't often get we don't, and we do follow up, as Rita mentioned, we do follow up with all the reporters that report to us. They don't all respond, so we're limited by that. But if it impacts the error, we can certainly try to follow up and ask more questions around that, or even type of technology they have too, right? So like those working conditions, there's a lot of factors that go into play there. From the number of pharmacists, the number of techs, the training of both, the number of clerks, what technology they have, and then of course the volume and hours as well. Mm-hmm. But it certainly does come into play, and something we do look at when we have the information.
Well, I would just supplement by saying that, first of all, I've been alarmed in seeing the consumers report commenting on how busy the pharmacists are and how understaffed they are in some of these reports that we have gotten, first of all. And second of all, while we can't really always tide errors that are reported to us with workload, or when we go in and investigate an incident, if we're invited to go in and investigate an incident, we definitely take into workload and the working environment as one of the factors that we evaluate as a contributing factor.
Correct.
Okay.
And definitely in our RCAs, yeah.
Yeah. Yeah, and Rita said like that, the consumers give us a unique insight. So they definitely are free to tell us their perceptions of the scene behind the counter, their perceptions, and it's not lost on consumers at all. And even that, the example of the newsletter I have for the newsletter is one highlighting a number of those types of cases where they identify the busyness and the lack of response, or the fractured response they get because of the stress the staff are working under.
Okay, thank you so much again, and I am sure we'll be hopefully talking to you guys more, and really appreciate your time. Thank you.
Yep. Our pleasure. Thank you.
I'd like to, this is Cheryl, and I really appreciate the presentation. I was just curious because I did not know about this institute, and you say you've been around since 1975. How do you put the information out there that you're available for pharmacists to contact you?
Well, I wanted to, we started the work that our founder has started was since in the 70s, but our institute was officially incorporated in 1994. Yeah, so we've been around officially since 1994, but the work has started back in the 70s. And so how do we get the word out there to the communities? I would say that mostly through our newsletter subscription, and we are a lot more effective in getting the information out to hospital and health system pharmacies in more acute care setting. And there's our success. We have a lot of success in getting folks engaged in some of these safe medication practices in the acute care setting and in community, in their pharmacies that are affiliated or associated with the health systems. We don't have as great of a presence as we would like to have in the community setting per se, and that's really, I mean, a lot of our work is really through presentations at conferences where folks go to, and also subscription of the newsletter and educational webinars that we do. Michael, do you want to supplement anything?
Yeah, I think, yeah, I mean, a lot of it's been word of mouth. We have had efforts to try to get information or share information with schools of pharmacy as well as state boards to disseminate to their staff and members. And that ebbs and flows in success over time, especially as staff changes and board members changes. That there's that just like in pharmacies or in hospitals, when staff changes, you have that loss of institutional knowledge and how that's sustained. Yeah, it's a challenge we continue to try to address, how to get the information into the best hands. Yeah,
I can say that I truly appreciate hearing you and to know about this Institute for Safe Medication Practices, because I really think it is necessary, and I really appreciate that you guys even exist, because I didn't know. Thank you.
Thank you.
I'm not sure about the protocol. Is there a raise hand feature? This is my first meeting, so I apologize if I'm out of order. The chair will let me know. But I just wanted to echo, as someone, consumer going into pharmacies, talking about how overstaffed they are, and how that can contribute to medication error. And I'm hoping that, I don't know how the discussion or where this fits in, but how do we mitigate that, right? In terms of staffing, and what is the work that we can do. The other point that I wanted to make was also around if the public education committee can help to also spread the word about the work that you are doing, since, as the other committee member noted, wasn't even aware of the great work that you're doing. So maybe that's something that can also we can take on in public education committee. But thank you again for your presentation.
Well, thank you. We would definitely appreciate any means of spreading the word about the work that we are currently doing. One thing I do want to, as I'm thinking about the question regarding vaccine safety, one thing I do want to point out that we have been advocating, especially now during this COVID vaccination, like COVID pandemic, with vaccinations being conducted in a lot of community pharmacies, is that dedicated time and protected time to be given for vaccinations and immunizations. We hear all the time from the reports how the pharmacists are basically spread so thin they have to be responsible for all the dispensing and the counseling, and then at the same time someone can come in and they have to stop and do the vaccinations. And there are consumers who have complained about how busy the pharmacists are, that they have to wait for an hour or longer to get the vaccination. But on the other hand, that distractions and the busyness really does lead to a lot of errors that are happening when people are spread so thin. So one of our biggest recommendations to the community pharmacies and the chains is to really have dedicated time when a dedicated pharmacist can be providing the vaccination, rather than just having to go back and forth with dispensing and vaccination at the same time. So if anything we can do right now, it is really to get people to have that kind of protected time and designated time frame when the consumers know that the pharmacies are providing vaccination, and then there is dedicated staff to do that work.
Great. Any other member comments? Jig, did you have any comments? I saw you were off mute.
I did. Thank you, Nicole.
You're welcome.
Thank you, Rita and Michael, for coming out and giving the presentation and further answering questions that the committee members had that did shed a lot of light on other issues in error prevention. One of the questions I had, and I don't know if you have that data or not, but to protect Californians, the California board has a quality assurance form that pharmacies are supposed to fill out after the internal incident reporting of errors occurs and keep it on file. And it requires group meetings, etc., looking at why this error happened. Do you have any data of with whoever you're working with in terms of institutions, hospitals, retail? How effective is that when a pharmacy does a QA after an error happens and they implement those changes? What are the chances of some of those errors happening again after they do that homework? Would you have any information on that?
I don't. Michael, do you want to start out? I don't believe we have those information, but I have. I certainly have my perspective on that.
Yeah, I wouldn't say we have any data that we could point to as far as numbers or percentages or things like that get reported to us. Part of the work that we do is we do healthcare facilities, institutions, pharmacies can bring us in to look at their medication use processes, whether it's in response to an event or proactively.
Yeah. So
I think that's probably where Rita's kind of going down the path in her experience.
Right. So I would say that how effective that requirement is all dependent on how seriously folks take that quote task. There are certainly pharmacies who take that very seriously and try to implement action plans to prevent errors from happening. And there's certainly pharmacies that are just writing it on a piece of paper so that when the board inspector comes, they can show them this is our QA plan. I think that for a program to be effective, there has to be follow-up plans to know that, to keep track of your metrics, to understand that whatever steps that you have put into place to prevent the error from happening is working, that you're not seeing those same errors coming back over and over again. So I would say that from personal experience, sometimes when agencies such as the California Department of Health has required a medication error reduction plan and then asking folks to really trend the data to show them that the plan is actually effective is when you see some really effective programs going on. But the data, as far as data goes, from our end, we don't have data to show whether any of these programs are effective. I think on an individual institution or a pharmacy per se, really it is how the program is being implemented. So you can have a requirement, but if someone is just completing the paperwork and just moving forward, then it's not going to be an effective program. The most effective programs are the ones where people take it seriously and really monitoring to make sure that the same errors are not happening again, to know that the plan is working. And if the same errors happen again, then you may need to change your plan and just have iterations of plans and look into the issues to make sure that you have effectively put in something to prevent the errors. So that's kind of my 2 cents about that.
Yeah, and just to add on, I mean, I think, coming out of, I think a lot of practitioners, aren't taught or don't learn or have, easy opportunities built into curriculum to learn kind of that continuous improvement process and identifying errors, identifying strategies, and monitoring effectiveness of implemented strategies. We certainly, hear and see a lot of folks, over the number of years where folks have put in strategies, and like to Rita's point, they put them in and they think it fixes the problem and don't really understand that there's a whole monitoring and metrics piece, and you need to continue to get feedback from your frontline practitioners about how things are working. I just think there are a lot of people, like that's not really being taught in schools.
Very true.
And it's hard, so we're, I think in general, at a disadvantage because, schools are set up to teach the clinical pieces of pharmacy, which is obviously important. And we try to really encourage schools and actually teach classes at Temple University here in Philadelphia, Pennsylvania, around risk identification, risk management. But that's not widespread. And so we have folks coming out, well, it's physicians, nurses, pharmacists, not really armed or exposed to continuous, process and quality improvement and things like that, and error reduction and error identification, and really rely, once they get in practice, whatever their practice site is doing, which some do well and spread that out. It's particularly in the acute care setting that there are higher performers when it comes to with respect to that. But into the individual pharmacies, you're going to have a lot more diversity in what's taught and how things are handled. So, like Rita said, we don't really have hard data. Certainly have anecdotal stories, but just keep in mind, like we're not really arming our practitioners when they're coming out of school with the necessary tools to really do this once they hit the ground as a licensed professional.
Yeah,
Right.
I mean, that was my second question was that, institutions, colleges that are graduating all the healthcare professionals, I mean, definitely should have safe medication practices as part of the curriculum. And I believe the first day any professional goes to work, the biggest thing on the mind is, I don't want to make a mistake.
Absolutely.
I remember my first day of practice, and you keep going back and keep looking at the prescription you checked, right?
Right.
So
Right.
I'm sure no professional out there wants to make any error knowingly or
Absolutely.
or fill out a QA and not follow up on it, and so that they can make the mistake again, so to speak. But yeah, I mean, your the knowledge base you have and the data you've collected over a period of years, I think the school, college of pharmacies, and all other institutions that graduates, healthcare professionals could definitely use that data to graduate a healthcare professional that will do what it takes to prevent errors.
Right. That would be our bias, is that every school of pharmacy has at least a course to teach about how do you prevent like medication errors, how do you do an investigation, all of the stuff that Michael has talked about, not things that most school of pharmacy teaches. That will be our bias, that everyone should have a course in medication safety in their curriculum before they come out to practice. Yep. Oh, I think the other thing I do want to address is really the cultural difference between an institutional pharmacy and a community pharmacy when it comes to medication safety. There's definitely a much higher awareness of how you can prevent medication errors from happening in an institutional setting, and a very different safety culture in the institutional setting versus a community setting that I think really would use some work in improving, so that our public, ultimately, the community pharmacies is where a lot of our public is getting the medications from, much far more than in an acute care setting, and yet that same scrutiny and same type of work that is being done is not being done, I guess, in the community setting. In general, I think that's where we should probably start is instilling that culture of safety and having people understand that the different strategies, I mean, we have different levels of strategies to prevent errors from happening. Just informing the staff and educating them is the lowest level strategies you can ever use to prevent errors from happening. Those are the kind of things that is really worth spending time on educating community pharmacies folks on how do you implement a high leverage strategy to prevent medication errors from happening.
Absolutely. Great work there. Thank you for the contributions.
Thank you.
Great, thank you. What a great discussion. Thank you so much, members. Really quickly, before we move on to public comment, I just wanted to ask, could you give us maybe the top, I know we've talked a lot about staffing, but could you give me maybe the top 3 causes that you see for medication errors in your work?
That's a great question. The top 3 causes. I can't say that off the top of my head, Michael.
Yeah, so when our error reporting programs, the medication ones, not really built on volume. We're really focused on getting good quality reports and understanding the system failures. And there's lots of things that happen. So, I'll just say, I think things, I don't know that these are going to be the top ones, but we certainly get a lot of reports of wrong patient errors in community pharmacy, whether that happens at the point of sale, where the clerk, the technician, the pharmacist grabs the wrong patient's bag and hands it to the person, or during bagging of those prescriptions, multiple patients or consumers' prescriptions get combined into the same bag. So I know that's something we often get from consumers. Also from consumers, again, I don't know how it's frequently reported to us by consumers. I don't know how frequently it's happening in practice. A lot of wrong quantity or wrong count errors, even with controlled substances, where people are reporting to us having been shorted or even given excess amounts of medications. And then, certainly getting, wrong dose, wrong drug reports as well, but to quantify them as the top 3. I mean, those are things that are coming off the top of my head. And some of those are influenced, at least the wrong drug and the wrong strength, even the wrong direction sometimes. And I think technology has a role to play. We do a lot of try to advocate for improvements in electronic prescribing and other things like that. I think there are still gaps there that are impacting pharmacies, where that transmission of those electronic prescriptions are not seamlessly going from prescriber into pharmacy system, and there's still a lot of manual work that is having to happen on the pharmacy end, where things are getting misselected, or how prevalent barcode scanning is in pharmacies and how effectively is that deployed. Rita, those are things that come to mind, and like I said, certainly from a consumer perspective, they're largely reported to us wrong patient, wrong count errors. Rita, do you have any other thoughts?
Mm-hmm. Yeah, but the root cause of the errors is difficult for us to pinpoint as what is the top 3 causes. I mean, we know some of the types of errors that is reported to us, but not being able to go and investigate all of these, it would be hard for us to say that we know what the top three. I mean, I would imagine that the workload is probably one of them, but we don't have any data to say that for sure this is.
And again, I think it goes back to things we were talking about as far as how well prepared practitioners are to identify causes and contributing factors. Yeah, I don't, on the whole, again, we're just not well prepared to do all that. And so there are, things that people point to, but there are probably deeper, more, other issues that are actually happening that could be corrected and be less reliant on human performance. Like we don't always get all the way down to what we would consider root causes based on the error reports we get.
Great. Thank you so much. So at this point, I'm going to go ahead and give the public an opportunity to provide comments. Moderator, can you please open the line for public comment?
This is the moderator. We've opened that Q&A panel. If you'd like to comment on the presentation, please click on the Q&A icon on your screen, type comment into the text field, and submit that to our panelists. As a reminder, each commenter will have 2 minutes to make their comment. Our first comment comes from Danny Martinez. One moment. Okay, Danny, I've sent you a request to unmute your microphone.
Can you hear me?
I can.
Okay, thanks. Hi, this is Danny Martinez with the California Pharmacists Association. Thank you to Dr. Zhu and Dr. Gaunt for this presentation. I'm not sure if you're familiar with the California Pharmacists Association. We are a association that represents the pharmacists in every setting, including chain and community pharmacy, independent pharmacy. I kind of want to follow up on some of the questions that President O and the chair asked about the kind of the root causes. I understand that when there's an error that's been reported, I'm curious as to how often on average pharmacists are reporting errors that are a result of being either burnt out or overworked, self-described burnt out or overworked, and how often they are actually resistant to actually reporting that. If you have any data on that, because that's something that we at the association have been working on now for a little over 2 years. I'm not sure if you're familiar with recently passed Senate Bill 362 that would ban certain quotas from being implemented in chain pharmacies. Interesting comments that I also picked up on where you were discussing the term, having a dedicated pharmacist to do one thing versus another. In our experience and based on the feedback of our membership, that's just simply not possible in certain settings. As much as they would want to, as much as they would begging to do that, for whatever reason, their place of employment is not allowing that to happen. And just yesterday, our association had we have these groups called the special interest groups or SIGs. Last night we had a meeting of our SIG, of the chain pharmacists, where they were repeating a lot of what we would normally hear, are some of these nightmare scenarios in their workplace, mainly in the chain setting. I'm sure you also saw yesterday on Bloomberg a story out of New York, a very heartbreaking story out of New York, of a pharmacist who was very afraid to go into work, afraid that she was going to kill somebody because because of med errors or because of the stress that was implemented on her. So
15 seconds.
Just to say, I want to introduce myself. We'd be happy to work with you at ISMP. I think we could create a good working partnership there. Thank you.
Thank you. And our next comment comes from Lindsay Goldhorn. Lindsay, I've sent a request to unmute your microphone.
Can you hear me?
We can.
Oh, great. Thanks. Good morning, Chair Thibault and committee members. This is Lindsay Goldhorn with the California Retailers Association and the National Association of Chain Drugstores. Definitely want to thank the committee for this discussion today, and our members take medication errors very seriously. Also thank ISMP for the presentation and their work today. I think one thing that we would suggest in this discussion and maybe at a future meeting is that the board look into and maybe hear from an expert about patient safety organizations, PSOs. PSOs were authorized over 15 years ago by Congress as a way to improve patient safety and reduce incidences that put patients at risk. And basically, the point of PSOs is to allow healthcare providers, including pharmacy members, to report medication errors, share best practices associated with these errors with confidentiality. So participating pharmacy members can track and study patient safety data, which can help identify patterns, which in turn helps them work toward prevention. So I think from our perspective, this is a critical approach to ensuring patient safety, and I think it would be worthwhile for the board to maybe explore this. Thanks.
Thank you. And our next comment comes from Michael Connor. Michael, I've sent a request to unmute your microphone.
All right. Morning, team. Hear me okay?
We can.
Perfect. I didn't get that intro tone, so I wasn't sure. Thank you. So my name's Connor. I'm currently in a hybrid setting, but I used to be a PIC in the retail community setting here in the Central Valley. And Dr. Gaunt, you mentioned a very interesting idea around finding and identifying most errors, or a lot of errors at that point of sale, that touch point up there. And that reminded me of my own experience. And I recall being so busy, I had tiers set up where I would spend more time on, for example, pediatric patients or any type of mental health med or REMS med. That's where I would take that extra time. Outside of new meds, of course, making sure I interact with the patient, pull the medications out of the bag. So we had an informal process and tiers for that worked really well. So I'm happy to hear that interesting idea from ISMP. A second brief comment. This kind of builds on Dr. Butler's point and other comments by our members and team. How have you, I know in our health systems, the reporting is, typically we have strong quality assurance processes that are encouraged and team members don't have any fear of retaliation or termination. But I sense, based on feedback, that it's the opposite in our community settings, where there is a fear of prompting audits or a fear of encouraging reporting, unfortunately. How have you overcome that, or has that been on your radar? I know you briefly touched on it, but I'd be curious to learn more. Thank you.
Thank you. And with that, I do not see any other requests for comment. Would you like me to close the panel?
Yes, please close the panel.
It is closed.
Thank you.
Chair Thibault, hi, this is Eileen Smiley. I just wanted to remind the committee that sometimes public commenters, people use it for question and answer to the board or to the presenters. However, you don't have to answer each comment or question if you don't want to. If the committee wants to have discussion about some of that, that is, of course, permissible, but you don't have to respond to every question raised in public comment.
Thank you for the reminder, Eileen. Members, did anyone have any comments or want to address any of those questions at this time?
Well, I'm actually curious, Song, about the question that was raised by, I think, Mr. Connor, I believe, Dr. Connor. If Dr. Zhu or Dr. Gaunt has any response to that.
Are you still on?
Yes, I am. I'm sorry. I needed to. I did not. Can you help me identify the question from the comments, because I did not associate the name of the person with the question.
I think it's the last commenter asking about the retaliation and some concerns that he had, possibly people not reporting because of whatever reasons there may be.
Sure. Well, that's definitely something that we at ISMP we speak a lot about, is the fact that there has to be, and that kind of goes back to my previous comments about the culture of safety, that there has to be an environment where people feel empowered to report errors. There's definitely concerns. I do see that there are concerns about reporting errors because of retaliation, and very frankly also the fact that it could be a punitive things on licensees license. So there's definitely some work that needs to be done to ensure that folks, we at ISMP, we strongly believe that the only way we can prevent errors from happening is through people reporting it and investigating into these errors to understand how the errors are being made, and hence coming up with action plans to prevent them from happening. And so that's the root of our existence, and that's the reason why we're here, and we spend a lot of time talking to reporters of errors to try to understand the situation. So when we write about that and we share the information, so we understand the root cause of those individual errors. So there has to be system in place to ensure that people who are reporting these errors would not, first of all, feel like they would be retaliated against, or it is not the culture where people think that their peers is going to be upset at them, or that when you're reporting an error, you are going to be your performance evaluation, for example, is going to be affected because you might have reported an error that you have made. So there has to be a healthy culture in the environment where folks will be reporting these errors. Because the reality is we are not at a point where nobody makes mistakes. So when you don't have errors reported, you just know that people are just not reporting it. And until you have these errors reported, you're not going to be able to fix the problem. So we definitely echo the fact that a healthy culture of safety is important for us to do any work to prevent medication errors from happening.
And I would just say that retaliation, we hear stories about, from employers, but also from regulators. And we've done work over the years for different components of that. In for instance, like working with the National Coordinating Council for Medication Error Reporting and Prevention to come out with a statement. This is going to go to the criminalization piece of human error, but to avoid criminalizing human error. Doing work with that and being very public in newsletter publications and other statements, when it comes to that type of legal action or retaliation as well. But it is certainly something we hear about, and certainly concerns from practitioners in pharmacies or in hospitals. And I think even just like in December this fall, we wrote an article in the community newsletter about tips for increasing reporting of errors. And that's a significant piece, for practitioners to have the psychological safety and the support of institutional leadership, but also, of regulators to identify and report errors so that things can actually be corrected without fear of punishment for human error.
Great. Thank you so much. Again, Dr. Zhu and Dr. Gon, I want to thank you for your time.
Chair Tebow? Hi, this is Eileen. I just wanted to check to make sure, because public commenters didn't get a chance really to comment about this portion of the presentation and the retaliation aspect, that we should probably open it up for public comment on that point alone and just ask previous commenters whether to narrow their comments to what was just discussed by Dr. Zhu and Dr. Gaunt.
Thank you, Eileen. Moderator, could you please open the line for public comment?
This is the moderator. We've opened the public comment period. Again, if you'd like to make a comment, please use that Q&A icon to submit your request. Click on the Q&A icon, type comment into the text field, and submit that to our panelists. Not seeing any requests. Would you like me to close the panel?
Yes, please go ahead and close the panel. Thank you.
You're welcome. It is closed.
All right. With that, Dr. Zhu and Dr. Gaunt, thank you so much for your time today and your dedication to improving patient safety through your work with ISMP. This has been a wonderful discussion.
Well, thank you. Thank you for having us.
Thank you.
Much appreciated. Board members, I would like to propose a break. What do you all think?
I agree.
Sounds good.
Okay, great. Do we want to do 10 minutes?
That's good.
Okay, perfect. Thank you.
Thank you.
If everyone's back. Can I start with President O?
Hello, Nicole. I'm here.
Hi. Cheryl?
Here.
Thank you, Cheryl. Kula, have you returned?
I'm here.
Great, thank you. And Jig?
I'm here.
Great. Okay, then I think we can get started again. So now we are going to move back to agenda item 3, which is the discussion and consideration of the results of the workforce survey. Members, as you may recall, during the December 2021 board meeting, we received a presentation on the results of the workforce survey conducted by the board. I have asked Anne to review some of the survey results today. I note that the full presentation results are provided in attachment 1. Anne, the floor is yours.
Thank you very much. Moderator, if we could go to the next slide, please. So as you may recall, last year the board developed a survey, workforce survey, intending to really get to some information at community pharmacy specifically. So we asked some demographic information at the beginning of the survey to really kind of make sure that we were understanding the responses that we were getting. So I'm not going to go through all of the demographic information that is included in the slide, but what I focused on this slide specifically was really to kind of talk about the world that we referred to when we were discussing the subsequent questions. So we really focused on pharmacists reporting working in community pharmacy, whether they were in the chain environment or independent environment, and that they were working in California. So when we look at this slide, I chose this slide just because it talks about kind of what those response rates were, and then it gives you a little bit of a profile about whether or not they were working as a pharmacist in charge in that area. So from an orientation standpoint, this slide breaks out the responses by those pharmacists working in a community chain pharmacy versus those working in a community independent pharmacy. So a response rate was higher for those reporting as working in a community chain pharmacy versus those working in a community independent pharmacy. You'll also notice from this slide that the percentage of respondents in those respective environments for community chain there was a higher percentage of pharmacists that reported not being a pharmacist in charge versus a community independent pharmacy where a higher percentage of the respondents were pharmacists in charge. If we could go to the next slide, please. So we asked a variety of different questions, and really, right, we were looking at what is happening in pharmacy right now. So one of the questions that we asked about was what was the average prescription volume during a typical shift? And right, with a survey response, we are collecting people's beliefs in something. So this slide reflects what people's beliefs are with respect to the prescription volume during a typical shift at their work site. So you'll notice that in a chain pharmacy, you're going to see typically a higher volume of prescriptions than maybe those in an independent pharmacy. If we could go to the next slide, please. We also asked about the different types of services that are provided at the pharmacy, right? A pharmacy provides far more services than just dispensing medications. It's really a great place for a number of healthcare services, including receiving immunizations. You can get some travel medications, so lots of different things. So what this question was really about was trying to find out what other services are provided in these work sites. Again, we're trying to get to what is the overall workforce picture looking like in these environments. Next slide, please. So one of the questions that we asked about was whether or not, as a pharmacist working in either a community chain pharmacy or an independent pharmacy, if you're required to perform those additional services. And what we find is that the vast majority of pharmacists that report working in a chain pharmacy report that they are required to perform these other services. Whereas if you work in a community independent pharmacy, you're less likely to be required to provide those other services. Next slide, please. We also asked about the number of immunizations that are administered during a typical work shift. And again, this is what the individual is reporting their belief to be specific to this specific question. And you'll find that as the frequency of the vaccines administered here kind of vary between the chain and the independents. I feel like it's important to note that at the time that we released the survey, COVID vaccines, had started. So when we're looking at the number of immunizations, a lot of this could be attributed to COVID vaccines. Next slide, please. So during the discussion, as part of the presentation in December, Dr. Tracy Montez provided a good portion of the presentation and highlighted some areas where they believed that the findings were statistically significant. And so this question specifically, Dr. Montez highlighted that this question, do you believe you have sufficient time to provide adequate screening prior to the administration of an immunization? 78% of community chain pharmacists reported they do not have sufficient time, whereas 56% of independent community pharmacists reported yes, they do have sufficient time. And that is an example of one of the reports from this survey that Dr. Montez indicated was statistically significant findings. Next slide, please. So we also asked about whether or not your work site uses workload matrix, and if so, if you could identify where, what those workload matrix are. So you can see that there's a large variety of different types of workload metrics that are used, and in greater prevalence in a community chain pharmacy versus an independent. And this was, again, another one of those questions that Dr. Montez has indicated she believes to be statistically significant. If we could move to the next slide. So we also asked about, does your primary work site have a work queue that monitors the wait time for prescriptions? And as you can see, based on the responses, a significant majority of those that work in a community chain pharmacy reported that yes, there is a work queue that is used to monitor the wait times for a prescription, whereas that same dynamic is less frequent in a community independent pharmacy. We could move to the next slide, please. We also asked about what is the average number of medication errors that occur in a month in your pharmacy. And again, this is based on someone's belief. So the data is reported, and if we could go to the next slide. Dr. Montes did indicate that there appears to be a slight correlation between prescription volume and the number of medication errors that are found. And what she indicated is that the greater the volume, the greater the number of errors. But she also indicated that further analysis would really be needed to determine the strength of that correlation. If we could go to the next slide, please. So question 26 spoke to whether or not a pharmacist believed they had sufficient time to provide appropriate patient consultation. And what we notice is that 83% of pharmacists that responded to this that work in a community chain pharmacy indicated they do not believe they have sufficient time to provide appropriate patient consultation. However, if you look at those that report working in a community independent pharmacy, only 32% indicated that they did not have sufficient time. Next slide, please. We also asked, do you believe the pharmacy staffing in your primary work site is appropriate to ensure adequate patient care? And again, if you look at the community chain pharmacies, 91% of the pharmacist respondents indicated they do not believe the pharmacy staffing is appropriate for their work site to provide adequate patient care. When you look at community independent pharmacies, 37% indicate that they did not believe that they had sufficient staffing at their primary work site. So when we're looking at a lot of this data and then taking into account some of the information that was just shared by ISMP, as well as some of the information that we've been, hearing about in the media, those kinds of things, I think it all kind of helps to create a bit of a picture as to what is happening in terms of work sites in pharmacy right now. And I think that is it. If you could go to the next slide, please. So I'll open it up and turn it back to you, Chair Thibault. Thank you for your time.
Thank you so much, Anne. That was very helpful. Members, I understand that the data reflected represents individuals' beliefs in response to questions, but I'm extremely troubled by some of the findings, including the extremely high percentage of pharmacists working in a community chain pharmacy that responded that they do not believe they have sufficient time to provide adequate screening prior to administration of the immunization. Equally troubling is the very high percentage of pharmacists working in a community chain pharmacy that indicated they do not believe they have sufficient time to provide appropriate patient consultation, as well as that 91% of pharmacists working in community chain pharmacy do not believe the pharmacy staff is appropriate to ensure adequate patient care. As we move forward as a committee, I think we need to keep these survey results in mind. Now, I would be interested in hearing from other pharmacy members, board members.
I'll just jump in, Nicole, if that's okay. This is Song. I have a couple things that I'm curious to see what we can do further. Obviously, it's one survey, and I apologize, Anne, in advance that I will make you guys work more than what you already have ongoing. But I'm curious if there's a way that we could do some sort of an in-depth survey subsequent to these surveys just to get some clearer understanding. And I'm also hoping if we can do more dive down into these data in some capacity. I don't know what, I'm not a statistician. I really can't say, but obviously there's something going on in here for such overwhelming majority of pharmacists to think that one, they don't have sufficient time or to really check the accuracy and that there's no time to do consultation. So hoping for some sort of another secondary survey, something else maybe, looking at more into the data, some sort. Hopefully we can figure something out working with our Dr. Montaz and Chair and figuring that out. So hoping for that to happen.
I agree with you, Sung. I think something else needs to be done. And one of the things we have is the number of complaints we received about medication errors. Should we consider diving into that in 2021, 2020, 2019? 2019 being pre-pandemic, and just to get some idea on at least that data on how many errors, how many complaints we received for prescription errors from consumers.
I like to make a comment on this also. I certainly would like to see, and was really happy to hear that CPHA would be working with ISMP to get this information out to the pharmacists. And I certainly appreciate Ann and the staff bringing the ISMP in, and I think the board should certainly be working with them also. I'm personally, I can see trying to get more information, but having been out there and going from one pharmacy to the other, I hear this all the time. This is no surprise to me. I've had pharmacists cry that I have these vaccines, I have these patients waiting. And again, I'm not at all surprised, and I don't think we're going to get anything different. But I do, and I respect my colleagues' opinions about that.
I'm wondering, how can we find out, or do we know what is the appropriate level of staffing that would minimize some of these errors? And is that something that we could pursue if we don't know? Because it seems to me, as the previous member just said, I am not a pharmacist, but I wasn't even surprised to see these results just based on what I see when I go into my local pharmacy. And so just wanted to see, how can we find out, what is the level of staffing that would minimize some of these errors?
That's a good question, Kula. I think it's industrial engineering, just like any other workplace. Number of tasks, number of steps taken, pretty in-depth in terms of if you want to get to the nitty-gritty of how each pharmacy is laid out, how many steps you have to take to go grab the bag. It does require quite a bit of analysis and study that are out there, including one of them is called Six Sigma, that works with many other work environments. But yeah, absolutely, that's one way of factoring that.
Or is that something that we can pursue in terms of just like as this committee?
I think so, Kula. I think that this committee is kind of, it's up to Chair Thibault, but I feel that this committee is in part to just kind of have a very bigger, broader scope to try to see what we can do. So yeah, I think that's a great point. And I am actually curious to find out if any of our colleagues on the retail side or anyone that works on these things to kind of present what they based their current level of staffing or whatever that may be. I'm curious to find out that myself as well, because I really haven't seen the behind the scenes work. And to me, obviously, I totally hear Member Butler and you, and I see it every day, everywhere myself. It's not just one anecdotal store; it's literally everywhere and anyone that I talk to. So clearly something's amiss. Clearly something is not adding up. So I think we need to look into that for sure.
Yeah, thank you. Thank you everyone for your comments. And Kula, that was you got right to the heart of it. You've got this down, even though this is your first meeting. I don't know the answer to that. I don't actually know exactly how we would do that, but definitely something I think that's worth looking into. So noted. Were there any other member comments before we move to public comment? All right, seeing none, moderator, can you please open the line for public comment?
This is the moderator. We've opened that Q&A panel. If you'd like to comment on this item, please click on the Q&A icon on your screen, type comment into the text field, and submit that to our panelists. Our first comment comes from Lindsay Golahorn. Lindsay, I've sent the request to unmute your microphone.
Perfect. Can you hear me?
We can.
Thank you. Hi again. This is Lindsay Golahorn with the California Retailers Association and National Association of Chain Drug Stores. Thank the board, the committee, and OPES for conducting the workforce survey last year, and thank you to Anne for summarizing the results today. Just want to reiterate that CRA and NACDS and our members are committed to the well-being of their workforce, including ensuring that pharmacists have the tools and support they need to safely serve patients. We also do understand the challenges that face the healthcare workforce, especially over the past year, as we've been working to get Californians vaccinated and boosted. As we all know, almost all sectors of the economy are suffering from lack of available workforce, in addition to necessary absences due to COVID illness and exposure. And of course, the healthcare workforce in particular has been under a lot of pressure. In the face of these circumstances, our members and their pharmacy teams have worked hard to push back against the current public health crisis, providing millions of COVID-19 tests and vaccines to patients throughout the country, all while ensuring that patients have access to their necessary medications. We understand the pressures our workforce is facing, and our members have undertaken a number of efforts to assist pharmacists and pharmacy employees, including robust training of all employees, bringing on additional employees for vaccinations, making IT enhancements to streamline workflow, adding human resources positions dedicated to hiring, adjusting hours of operation, cross-training front store employees to assist in the pharmacy, as well as salary increases, bonuses, things like free daycare and other social services for employees. As the committee examines approaches to reduce the occurrence of medication errors and improve patient safety, we urge you to consider solutions that will support pharmacies while reducing administrative burden. We definitely acknowledge the need for oversight and regulation, but do want to stress that every new regulation or requirement that's enacted adds an additional layer of administrative duties that's placed on pharmacies, which takes away from patient care. We'd also encourage the committee to explore providing more resources to pharmacy teams, including but not limited to expansion of the pharmacy technician duties and expansion of the pharmacist to pharmacy technician ratio. California has the most restrictive ratio in the country, and there may be a correlation between that and medication errors. So expanding the ratio, bringing on more technicians is one way to mitigate errors and protect patients as we talk about staffing. And I know this was discussed during licensing committee last week and will be discussed again probably today or tomorrow at the full board meeting, but another option is to allow for remote processing and alternative work environments for team members that may be experiencing burnout or need a environment. So these are just a few options that we think could reduce pressure on pharmacy teams and reduce the incidences of medication errors. We also agree with board member Patel that it would be a good idea to look at pre-pandemic data since the survey was conducted during COVID. Again, we're committed to protecting patients and ensuring our pharmacists and their teams have the support they need to safely serve patients, and look forward to continuing to engage with the board and the committee on this issue. Thank you.
Thank you for your comment.
Next comment comes from individual identified as initials SA. I've sent a request to unmute your microphone. Can a public member identified with the initials SA please unmute your microphone? You can click on the unmute me button that appears at your end.
It was actually more like a comment, the root cause of all the statistics that the board just demonstrated in the slideshow.
That's okay. I see that you typed your comment in, but we do need it read in for the record. So if you can please state it verbally, please.
Okay, I lost my verbiage, but I can summarize it that I no longer can see my write-up because I submitted it. But the bottom line is that the leadership at the retail level basically are encouraging, the statistics that you just demonstrated in terms of there's a certain quota the pharmacists have to meet, certain number of prescriptions and process certain number of prescriptions per day. If they don't, they get penalized. And as a result, the oversight on the technicians per pharmacists are rather substandard. There is inattentional blindness. They feel pushed and forced to deliver, which takes away from the quality of the service they offer. That's the gist of it. So if the root cause needs to be addressed, it needs to be addressed at the leadership of all the retail sector, basically. It's not the pharmacists. You have to dig deeper to go to the root cause.
Thank you for sharing your comment.
Our next comment comes from Danny Martinez. Danny, I've sent a request to unmute your microphone.
Thank you. Going off of what the previous commenter just mentioned, this is something that, again, CPHA has really been trying to work on and nail down. I also want to reiterate the concern that a lot of pharmacists have in terms of retaliation, fear of retaliation. It's one of the reasons why you don't normally hear individual pharmacists commenting here at board meetings. Whether it's a fear of being sought out or trying to find out who they are, going back to their workplace, initiating an inspection, and then having consequences roll down from there. This is one of the main reasons why our members come to us, tell us about it. And then we serve as kind of like that conduit to the board or to whoever else with those problems. I think one of the things that the board really needs to think about, whether it's in this committee or the full board, is somehow making it easier for pharmacists, individual pharmacists, to have that freedom to state what is really going on, what is really on their mind, and somehow either protect them, whether it's through whistleblower, through any sort of other regulations that the board can come up with. We're trying to work on that issue on our end, in terms of creating that safe space, so to speak. But that's really where I think this board will gain a ton more insight, is to create that sort of environment where pharmacists can really speak their minds. I tell you, even in spaces where I think internally we have opportunities to run, even some of our own members won't say anything out of fear that somebody will find out who they are or where they work. And that's, with even guaranteeing their anonymity. This is not an easy task, and we are certainly willing to help out with
15 seconds.
And we look forward to working with any group that wants to work with us on this. This is a very, very serious problem. Thank you.
Thank you, Danny.
Our next comment comes from Jessica Crowley. Jessica, I've sent the request to unmute your microphone.
For putting this all together. I am a staff pharmacist at a grocery chain, and I will say that the results of the survey are not surprising to me at all. I'm also a member of CPHA, and I work on their policy committee. I just wanted to reiterate what Danny Martinez just said in terms of retaliation, fear of coming forward about working conditions. I look forward to seeing what the board does with the survey and seeing a more in-depth survey afterwards. Some of the suggestions I would have for a follow-up survey would be asking more in-depth questions about what the technician ratio is for the pharmacist, how many pharmacists work in a typical shift at that store. And I also just want to emphasize too that the expansion of technician roles just does leave a little bit more error or room for error and oversight that the pharmacist would be required to supervise. So I do get a little bit nervous with the expansion of that role without additional support staff. And of course, as many of us know, we do have technician shortages in many regions across California. While we do have pharmacists who could potentially come on board and serve, for example, as an immunizer throughout the day if the chains were willing to actually have them on board. But I just wanted to thank you all for your time and your commitment to the workplace safety, and hopefully we get some good results moving forward.
Thank you for sharing, Jessica.
And it looks like we do not have any other requests for comment at this time. Would you like me to close the panel?
Yes, please close the panel.
It is closed.
Thank you, moderator. All right, so next we're gonna move on to, I think the slide is not right. I think we're on to agenda item 6. Oh, no, 4, sorry, we're out of order.
Excuse me, Nicole, can I just make a comment about the comments that were made?
Yes, of course. Thank you, Cheryl. And everyone, please forgive me. This is my first time chairing, so I'm a little awkward. So,
Nicole, you are doing a great job.
No, you're doing a great job. You're doing a great job, Nicole. And I just wanted to just make a comment on the fact that I do understand and again say that yes, okay, we can do another survey, but I believe the realities of this survey, and when I think about being on the board for about 8 years, hearing about working conditions, and then we having to go into SB 1444, 1442, no pharmacists left alone, because a lot of pharmacists were actually even working alone. And when I think about back 40 years when I started, before pharmacists had to have the add-on of giving out vaccines, travel medications, helping with smoking cessation, and all the requirements that we have now. But still, I totally understand, and I don't feel that we're going to get any different results, but I do understand the need to try to maybe to get down to exactly what it is. But personally, I do feel that it certainly has something to do with staffing, and it's not just because it's only gotten worse because of the pandemic, but it has always existed.
Yeah.
Thank you, Cheryl. Oh, go ahead, Jig.
Sorry, Nicole, I just wanted to, but yeah, I agree, Cheryl. I mean, it is to do with staffing. I mean, I was just browsing some of the job openings out there across California, especially in some of our rural pockets and all. And from pharmacist openings to technician openings to clerk openings, I mean, from retail chains to independent to hospitals, trying to recruit. I saw when I started practicing pharmacy, there used to be sign-on bonuses, which was not even seen anywhere, and I see those offered now. So I see that there is definitely a shortage of folks that are available in the workforce at this current time, and it is an issue with tech shortages, like one of the commentators expressed, and it became complex with pandemic, obviously, and it is causing a lot of discomfort working. There are times when pharmacy is open and there's nobody that could be hired, or so we have to look at it at many different angles. Who can do what kind of job duties, maybe taking some job responsibilities from pharmacists, empowering our technicians to do more who we have left in the workforce, ratios of pharmacists to technicians, so that if they are available, they could do more and frees up pharmacists for clinical. So it's a lot of avenues there. But thank you.
Thank you both for your comments. And I think it's really telling. It's complex. It's not easy. And I think this discussion is really demonstrating that. Eileen, do I need to open up for public comment again?
No, I think Member Butler raised her concerns before, and I think some of the concerns that Member Patel and Member Butler were talking about maybe go into item 7, the discussion and consideration of next steps for the committee, and then that way we can open it up for public comment again at that point.
Great, thank you for your input. All right, so now I will move us on to agenda item 4. Members, next for our discussion is the January 2022 Pharmacist Wellbeing Index State Report. The report itself and the published research ability of the Wellbeing Index to identify pharmacist distress are included in Attachment 2. The meeting materials detail out the key findings of the research. Most related to our committee, the reported information indicate that pharmacists identify as being at a risk of high distress are, among other things, at a 2-fold higher risk of medication errors. Members, I would welcome your thoughts on this report, including the findings. I would also be interested if you believe it would be beneficial to continue to monitor the state reports at future meetings. Further, would it be beneficial to request a presentation from APHA on the Wellbeing Index? Members, what are your thoughts?
Nicole, hi, this is Song. Yeah, I think that if APHA could provide some presentation, that would be wonderful. And I believe there are also some study, I don't exactly know the details that they're doing, hoping that would be also be presentable in the coming months.
Thank you. What do other members think?
Yes, I read the information, and I would definitely like to hear from the APHA. I would love to have a presentation from them.
Thank you, Cheryl. Jig, I think you might have a comment.
Yes, no, I agree. I think let's hear about it. We got to know, because pharmacist well-being is so important. That's how consumers can take advantage of the most trusted profession out there. And if they are not well, then it's an issue.
Great. Yes, I agree. I would love to have a presentation from the APHA as well, and I definitely think we should continue to monitor state reports. Any other member comments? Okay, then moderator, can we please open the line for public comment?
This is the moderator. We've opened the Q&A panel. If you'd like to comment on this item, please click on the Q&A icon on your screen, type comment into the text field, and submit that to our panelists. Not seeing any requests. Would you like me to close the panel?
Yes, moderator, please close the panel.
It is closed.
Thank you. Okay, we are now moving on to agenda item 6, the discussion and consideration of sample case investigations involving medication errors. Members, as we continue our assessment of medication errors, I requested staff prepare sample case investigations. I believe this information may help us understand more about different types of medication errors. At this time, I'm going to turn it over to Anne to present to us.
Thank you. If we can go to the next slide, please. So for purposes of the presentation today, I just want to say a few things. What we're providing is kind of high-level information. Some of it is things that we have already published in our newsletter as well. When we talk about investigations, we kind of try to keep it at the trending level as opposed to some of the more specific case investigations. So we're going to keep it pretty high level at this point for today's meeting. And then if there are specific items that you would like to take more of a drill down on, I'm happy to work with council and the chair to kind of figure out how we can get you more information that's really going to be helpful for you to understand some of it. So this is just very high level information, much of which has already been publicly reported. So the first is we're going to talk about immunization errors, and ISMP touched on this and we have released that alert. But we do see a lot of different kinds of vaccine-related errors. So we find that, there are a lot of, we see medication errors that come in the form of a patient going to receive a specific COVID vaccine and actually receiving one from a different manufacturer. And so in those cases, right, we look to the FDA and its approval under the EUA or now, formal approval depending on product to look to see how that's supposed to be done. And what we find sometimes is maybe there has been either the wrong second dose given of a manufacturer, or sometimes we'll see age-related. So someone that is, under the age of X receiving a vaccine that's not approved for that age group. We're also seeing investigations around the wrong type of vaccine. So the patient went in to actually receive an immunization for the shingles, right? But they actually received COVID. So we see those kinds of trends happening as well. We are unfortunately also seeing some investigations where someone is good to receive their vaccination and they are actually immunized with a previously used needle. So we've seen some of those. And then we're also seeing where vaccines are administered where the product was maybe not maintained appropriately. So it's either been past the expiration because of fine or whatever else. So we're seeing some of those things. The other thing that I highlighted on this slide, just to kind of like underscore kind of like where the obligation for consultation is. And I just want to really underscore that it's pharmacists, not pharmacy technicians, that provide the consultation, right? That addresses the side effects, maybe some OTC recommendations to manage those side effects. Want to really make sure that people understand that information comes from a pharmacist, not a pharmacy technician. So if we could go to the next slide, please. So my next kind of big bucket are medication errors that we see that kind of seem to be linked to auto refill programs. So this is really something that actually we run in our newsletter as well. But what we find sometimes is there was a failure to discontinue a previous prescription in an auto refill program when a new prescription for the same drug class is prescribed. So they're on drug A, the physician switches them to drug B, same category of drug, but unfortunately that previous prescription, that drug A prescription isn't canceled. So then it's auto refilled. And then the patient's taking two medications, within the same class. So kind of treating the same thing. We also look at we also find that drug utilization reviews maybe are not happening as they should with these auto refill programs, because if the DUR had been done, that duplication in therapy would have been detected and prevented instead of that medication, those multiple medications getting to the patient who then takes them. We do find that auto refill programs are also requesting renewals of medications when the patient is no longer on it. And so when that happens, then, right, the patient's receiving a medication that they no longer need to take, and then they are, ingesting it, and that can be a problem for a number of reasons. And then the other thing that we find is that sometimes the system has maybe flagged that there is a drug warning, like maybe through the dispensing process, and that's overridden. And then that results in the medication error. So those are kind of some big buckets for the auto refill types of errors that we see. And then if we can go to the next slide, please. So in a previous issue of the script, we actually did a couple of case studies. And so I've summarized them here, but you may want to go, it may be helpful for people to go to the newsletter themselves. So similar to some of the efforts that are undertaken by ISMP, sometimes at the staff level, we'll identify a matter that once it's closed, may be appropriate to share with everybody so that you can assess whether or not your pharmacy is at risk of making the same kind of error. So what we have on this slide is an overview of a medication error. This one stems from the use of accounting, an ads machine for counting, where the wrong medication was put into the canister. And so that's what that medication error stems from. If you read the full newsletter article, we also included a lot of discussion, so that may be helpful for people to kind of understand. So the whole discussion piece wouldn't fit onto the slide, but wanted to highlight this one. And then there's one more sample of that as well. Shelley, if you don't mind going to the next slide. So this is, another type of medication error that we see. And again, we highlighted in a past issue of the script. In the same vein as the last one, in addition to the overview and the conclusion, there was also discussion to kind of take a deeper dive into the facts of the case and what happened. So we keep it anonymous. We're not putting patient names, pharmacy, those kinds of things, but it's intended to try to help individuals understand kind of what happened and then look for steps that they can maybe take to prevent it from happening in their own environment. So that's really just kind of some high level information in some of the kind of bigger buckets of medication errors, if you will. And I'll turn it back over to you, sorry.
Great, thank you so much, Anne. That was very helpful. Members, what comments do you have or questions?
Hi, Nicole, this is Song. I'm sorry, I always jump in. I figure that, it's better to jump in. Couple comments. I'm curious some thoughts from other members and you on this. This is something that I've been always wanting to somehow make a progress on. And listening to Anne present about the DUR errors, it really is unfortunate. But I think I just wanted to bring the attention of maybe in this matter, if we could be audacious and ambitious enough. I know it's possibly very difficult, but I think it also takes should be consideration about how difficult it is for a prescriber and pharmacist to communicate in this day and age. I know many cases, many of the questions that a pharmacist would come up with during the DUR reviews, the questions the pharmacist could get a hold of the doctor, it would have been resolved in like 30 seconds. But I know many situations where pharmacists are on hold for 30 minutes, speaking to someone else, who's speaking to someone else, who's speaking to someone else. And I know that this is maybe a little difficult issue for us to resolve here, but at least we should discuss is the interoperability maybe of pharmacists being able to work with the prescribers in communicating in some fashion, because that really would resolve huge part of the problems that's going on and a lot of DUR problems that is going on. So hoping that we can take a look into that as well, maybe working with the prescriber boards like medical board and the physician's assistant boards, and maybe getting some opinions from the, IT systems vendors or privacy experts on HIPAA laws on how we can actually work together on this issue. And I'm sure this is not the first time this is being brought up or discussed as a nation or, even us, but I think that needs to be brought into this consideration because that's a huge barrier for pharmacists to really being able to take care of patients because all you are dealing with is just a prescription and you're trying to figure out everything and anything about that one prescription. And oftentimes prescribers don't put a note on, that's the only way they can really do it. And with the script standards being updated, they're supposed to have an advanced functions with other EMRs and communicating, but I know that it's still so far away from actually being helpful in current day and age. And secondly, about immunization error, it's really, really concerning. I applaud all the pharmacists out there really doing their best to take care of patients. And I know we sent out the alert to all the subscribers as a subscriber alerts of the right way to do it per ISMP, per what we believe is the right way to do it. And I still see many, many situations out there that it's really not being followed. And I'm hoping that we could hopefully make some progress on making sure that we have a system in place so that those horrifying errors, it's if you really think about it, it's a horrifying errors to be injecting someone else with someone else's needle that may have been injected to someone else. I mean, that is just frightening to even think about it. And we really have to, really think about, there's got to be a better way. So just those two comments.
Thank you, President O. Always appreciated. Jig, I think you have a comment?
Yeah, Nicole, thank you. One of the comments that Sung made about ability of a pharmacist to communicate with the doctor, or I'm talking about scope of practice here, where in a hospital setting, a lot of pharmacists can make so many changes on their own without consulting with the supervising pharmacist, MD. And in a community setting, if there is an intervention needed, their ability to, even though having the clinical knowledge and having the profile in front of them and knowing what could be done, it's the matter of having to talk to somebody is a barrier. And how we can empower them in various different settings. I think that's something that a committee can recommend to the board and have a broader discussion around that. Again, it's complex, like Sung mentioned, but we are part of DCA, and so is the medical board. And if we all work on it together, we can probably figure out a solution, empower them, remove the hurdle, and make them efficient. And at the end of the day, the consumer is going to benefit a lot if we can remove that hurdle from between. Good point, President Sung.
Thank you, Jig. Any other member comments?
I just have a problem with the idea of what would cause someone to use the same needle. Is there someone that's being rushed? Or is this someone that's just really not paying attention? Even going through the DURs on the computer, what does that take? Just take and look at what's showing up on the computer. So I don't know. Again, I'm still thinking, is this being caused as a result? Because of staffing situations? I do understand and agree that it would definitely help if you're able to communicate with a physician. I mean, with corresponding responsibility, I mean, pharmacists should be able to get a hold of a physician in cases where it is absolutely necessary. You know, I can remember a time when I used to can call and they had a line for the pharmacist and we could talk to the physician pretty fast. But today, again, with a pandemic and the problems that we're having with staffing with pharmacists and physicians, I can certainly see that would be a problem. Anyway, that's just a comment I have on this particular situation. Thank you.
Yeah, I just wanted to, member Patel made a comment about scope of work. And I just started to think that if we're, thinking about adding to that scope of work, but we also just had a discussion about pharmacists being, kind of stressed out, a lot going on, understaffed. So if we're thinking about adding this to the scope of work, I don't know if that means that that's just additional responsibility. That's more stress, and we already are understaffed. So I just wanted to, point that out as well. That's what came to mind when that suggestion was made.
Thank you all. I really appreciate the comments. I just wanted to talk a little bit about what President O had mentioned, and that came up a lot of times. Yeah, getting a hold of providers can be very, very difficult. It would be great if there was a better solution or expectation. Very disappointing as a pharmacist when you call a medical provider about a potential error and they're angry with you or refuse to answer your questions. And that happens, unfortunately. So it'd be great if there was like a shared expectations. I also wanted to just kind of throw in a plug here because it came up that an acknowledgement that there are some pharmacies that are kind of stuck in between designations. For example, I work in a pharmacy in a clinic. We are categorized as being a community pharmacy, but we have access to the patient records. So a lot of the time when we need to reach a doctor, we can see the answer in the medical record, but we still have to go through the process of reaching the doctor because our laws do not recognize that there are this type of pharmacy where we might have that access. So something that we may want to think about in the future. Lastly, we're talking about auto refill types of errors. And I think that there's not a lot of understanding among patients of why auto refill can be difficult, can be dangerous. So I'd love to think about maybe a little bit of education around that, because that's something patients request constantly. And it's very hard to tell them, no, we can't just blindly refill all of your prescriptions. There's a process behind that, and I think some patient education would help. So with that, moderator, could we open the line for public comment?
This is the moderator, and we've again opened that Q&A panel. If you'd like to comment on this item, please click on that Q&A icon, type comment into the text field, and submit that to our panelists. Our first comment comes from Connor. Connor, I've sent a request to unmute your microphone, and as a reminder, you will have 2 minutes.
Thank you so much again for this. It's wonderful to engage with the board this way and to learn so much. So thank you, everyone. This is Mike Connor again. Just briefly on the drug utilization review. I found that particularly interesting because the way most retail systems are built, or the ones I've worked with in Rite Aid, for example, or CVS, it's you cannot verify or move that prescription or sell that prescription until that utilization occurs. But I do know when you're verifying some 500 prescriptions a day and you're doing it quickly, and when duplicate therapy flags for a number of reasons, including a refill that might be a couple days early, I can see how easily that step might be overlooked because then you have to click into the profile and dig a little deeper. But that was interesting to see. I'm curious to learn more about that and learn more about how that step was skipped or what's behind that. But again, thank you, team. I really appreciate this opportunity to engage.
Thank you so much for your comments and participating.
Our next comment comes from Lindsay Gullahorn. Lindsay, I've sent the request to unmute your microphone.
Thank you. Hi, this is Lindsay Gullahorn again with the California Retailers Association and the National Association of Chain Drugstores. And just a real quick comment. We agree with President O that it would make sense for the board to engage with other licensing boards to ensure awareness among and communication with prescribers. For example, prescribers are able to cancel prescriptions through scripts, which I think is a newer functionality, but many of them might not be aware of that. So maybe if the board does engage, they could work with the medical board, the Board of Registered Nursing on a prescriber education program so that prescribers are aware they can utilize that function. And so that pharmacists and prescribers can more easily communicate. Thank you.
Thank you, Lindsay.
I'm not seeing any further requests for comment. Would you like me to close the panel?
Yes, please.
It is closed.
Thank you, moderator. All right, so now we are going to move on to agenda item 7, the discussion and considerations of next steps for the committee. Members, I would appreciate your thoughts on how we move forward as a committee, including a focus on where we are now in this moment in time and where we need to go. It is my understanding that NABP will be releasing a task force report on workforce, as I believe workforce is, in part, potentially a contributing factor to medication errors. I suggest that we request a presentation from NABP on the task force findings, if available, as well as information on efforts at the national level. Another area that may be interesting to explore, given some of the information we received, is perhaps a presentation of sample case summaries focusing on medication errors that could have been avoided if patient consultation was provided. Members, can I please request your feedback?
Nicole, thank you. This is Song again. That sounds great. I think those are great next steps. And I just like to add, if possible, some logistics may be a little challenging, but I do think we need to hear from our practicing pharmacists out there somehow, some way. I know we need to blast this out and that letting everyone know that this committee is ongoing and that we are trying to really understand and to try to see if there's a way to make some sort of proposal that would make things safer for the California consumers. And that'll take having pharmacists who's actually helping consumers out there to see their feedback. So logistically, I'm not sure, but I think we need to have a similar sort of listening session like how we are going to start for Tech Summit. I think we need to, maybe have a sessions, 2, 3, 4 sessions of inviting pharmacists, technicians, consumers, anyone that would like to speak and tell us what they think, what they see, what they feel, could be helpful. I think we need to try to see if we can make that happen. And I don't know if that requires a motion. I don't know if that requires actually just you and chair and the EO working together. But whatever that may be, I think that would be hugely helpful.
Great, thank you. I'm going to have to look to Anne and or Eileen as to whether or not we need to do a motion on that.
I'll just jump in. This is Anne. I don't know that you need a motion. I think that you're giving, direction to the chair on, steps to take. But if council feels otherwise, we'll defer.
Thank you.
Hi, no, this is Eileen, and Ann beat me to the punch. I don't think you need a motion. I think at this point you're just trying to identify for the board what you consider the next steps, would be, and just report out. But let's just see if we can get a list of all of them, or I'm sure you're still going through all the member comment, correct?
Yes, we are. Okay, great. Thank you so much. Other members, what are your comments? Jig, I see you.
I think we should hear what NABP has to say so we get a national picture. Saw some APHA data. Also, I would like to discuss what, as a committee, what we can put forward in motion with the full board meeting on some topics that we can act upon and make changes, simplify and act on it. And third approach, those are two things that comes to my mind. Let's take a national, more data on where things are, and then again during the next meeting, we can discuss, make motion to put something in the full board meeting agenda to discuss anything that we talk about in the next meeting with the full board.
Yes, I'm wondering if does, just for an order, does WebEx have a raise hand feature for the members? I think that might be a helpful feature if we can use it. But I was just wondering if the national survey that's going to be shared, is that going to help to give some information regarding the appropriate level of staffing that would reduce the errors? I know we talked earlier about that obviously being a big problem and us wanting to kind of, see if we can get some insight on what is the, best ratio. And Member Patel was talking about, Six Sigma and things of that sort. Just wondering if we would get a chance to hear some of that information.
Nicole, if it's okay, can I jump in really fast? This is Ann.
I was going to ask you to. Thank you, Ann.
Yeah, so Kula, thank you for the question. So I think, honestly, I don't think that we know yet because the report has not been released. Typically, when it's at the national level, the members of the task force will be bringing their different perspectives. And so I would assume that states that have undertaken some efforts, that information would be included in the task force report. But if we also ask the NABP, who's the National Association of Boards of Pharmacy, to also provide some information about what's happening at the national level in that area, they may be able to provide some information. Without going into too much detail, because I don't know a lot, I think that Oklahoma is taking an interesting approach with respect to a means by which to report working conditions. And so if that's something of interest, we could bring that forward. I think that there's one or two states that are maybe also looking at, statutory or, changes in the law to maybe address some of the staffing challenges as well. So I think that NABP will bring forward some of those, and then at the staff level, if the chair is agreeable, happy to work as well on trying to bring forward some of those in the future.
I am agreeable. I think that would be very helpful. Did we have other member comments? Cheryl?
Yes, I just want to also, I know we did mention that APHA presentation is something that would actually be part of our next step, correct?
Yes, that was brought up earlier as well. So you want to put that on the next steps consideration? Yes,
and ISMP, I was just thinking that it would be nice if I don't know how that would be done for our pharmacists to just know that exist and that we work with ISMP also.
Great, thank you, Cheryl. I think something that I heard earlier, which has come up in other areas as well, was kind of having an anonymous way for pharmacists to inform us of things, either us or maybe another entity, kind of like a whistleblower line or something like that. I have no idea of the feasibility of that or if it falls under our scope, but just want to mention it here as well. With that, I think we can, moderator, we can open the line for public comments.
This is the moderator. We've again opened those Q&A lines. If you'd like to make a comment, please click on that Q&A icon, type comment into the text field, and submit that to our panelists. Our first comment comes from Lori Walmsley. Lori, I've sent you the request to unmute your microphone.
On behalf of Walgreens today, speaking as an individual, I fully support the board bringing NABP in to speak from the perspective of the national lens. I myself am a board member in another state and participated in the NABP Interactive Member Forum yesterday and today. I didn't see anybody from California on the call today or yesterday, but there was a very lengthy discussion yesterday regarding this very topic. So NABP has a lot of great resources, and I would encourage California to participate with those. Thank you.
Thank you, Lori.
And I'm not seeing any other requests for comment at this time. Would you like me to close the panel?
Yes, you can close the panel.
It is closed.
Great, thank you so much. So members, before we adjourn today, I'd like to thank everyone for your time and participation. This was a wonderful discussion. I felt like we got a lot of information today and have a lot to work with. And our next meeting is scheduled for April 20th. So thank you all very much.
Thank you, everyone.
Thank you, Nicole. Good job.
Thank you.
Thanks. Thank you, Nicole. Thank you, everyone.